Muy buenas noches, nuevamente con la Universidad de los Andes y Singh. Estamos partiendo un nuevo simposio, un nuevo webinar. En esta ocasión nos acompaña el profesor Singh, nos va a hablar de daño isquémico tardío en hemorragia subaracnoidea. Nuestro moderador será Mario Rivera, que es neurólogo egresado hace no mucho y que trabaja actualmente en el hospital de Puerto Montt. Les recuerdo que tendrán al final del webinar la posibilidad, o durante el webinar, la posibilidad de hacer preguntas que les vais contestando al doctor Singh. Les recuerdo que vienen otros webinars más y también les confirmo que efectivamente en octubre tenemos el Singh Online, que será sin costo y que probablemente después aparezca una diapositiva con más información. Así que, Mario, te dejo a ti a cargo del webinar para que puedas introducir al doctor Singh y partan con la charla. Thank you very much, Professor Singh.
Gracias, Jorge. Bueno, hoy tenemos la oportunidad de contar con el doctor Jeffrey Singh. Él es médico intensivista y además tiene formación en neurointensivo. Ya al momento se desempeña como jefe de la unidad de paciente crítico de la red hospitalaria de Toronto, en el hospital de Toronto Western, en Canadá. Entonces, la idea de hoy es poder conversar un poco sobre lo que dice el webinar de manejo médico moderno de la isquemia cerebral tardía en hemorragia subaracnoidea. Bueno, como ustedes saben, existe una serie de complicaciones asociadas a la hemorragia subaracnoidea. Inicialmente está el riesgo de resangrado, más tardío puede aparecer hidrocefalia, tanto precoz o después tardío, pero probablemente el vasospasmo y la isquemia cerebral tardía son de las más desafiantes, en el sentido de que muchas veces son difíciles de detectar y también de tratar, ya teniendo en cuenta que existe un amplio abanico en lo que es las manifestaciones clínicas y al mismo tiempo en la cantidad de terapias que se han intentado a lo largo del tiempo, algunas mucho más exitosas que otras. La actividad hoy día va a dividirse en dos partes. Como dijo Jorge, inicialmente habrá una presentación del doctor Singh, aproximadamente 30-40 minutos, y después habrá un espacio para preguntas a los asistentes. ¿Ya? Todas las preguntas las pueden poner abajo en el botón de preguntas y respuestas. ¿Ya? Son todas las preguntas anónimas, a menos que alguno se decida identificar, así que pregunten con confianza. En el chat del webinar va a aparecer una pequeña encuesta, que la idea es que la puedan responder, es apenas un minuto que les va a tomar. Para la organización es bien importante, pues nos sirve harto para poder tomar sus comentarios e implementar mejoras. De hecho, hoy día vamos a poder contar con traducción en vivo. Hay una opción para poder escuchar al Dr. Singh tanto en inglés como a la traducción en vivo, ahí en una viñeta abajo. Y eso es gracias a las sugerencias que hicieron de poder, de querer implementar la traducción. Así que bueno, le vamos a dar la bienvenida al Dr. Singh. Please, Dr. Singh, if you may.
Wonderful. Thank you very much. Here, let me just see if I can. Now, are you able to see my slides? Just to confirm.
They look all right.
Yes, we can see it.
Perfect. Thank you. And so thank you very much for the invitation to speak. And thank you also very much for the live simultaneous translation. As you heard, I'm Jeff Singh. I am honored to speak to you today about the management of delayed cerebral ischemia, which happens after subarachnoid hemorrhage. I'll first start to say I have no financial disclosures or conflicts of interest relevant to this talk. For transparency, I do work also as an organ donation specialist here in Canada and do research in that area, but none of that are relevant to this talk. So for the next 40 minutes or 45 minutes, I'd like to present a little bit about delayed cerebral ischemia that happens after ruptured aneurysms or after subarachnoid hemorrhage. This used to be typically known as vasospasm, but I'd like to present a little bit about our evolution in thinking about the pathophysiology of this disease, of this complication, and what it means in terms of its detection and its treatment. We'll talk a little bit about how we do surveillance, or how we look for patients with delayed cerebral ischemia, and talk a little bit about a modern approach to treatment. In particular, we'll talk a little bit about the use of Milrinona, because it's something that we've been doing here in Canada for some time and have had a lot of success with. And we'll talk a little bit about how that is evolving as a therapy. So just as general background, of which you are all familiar, ruptured aneurysms are devastating events. About 10% of patients in Canada die before they reach hospital. Our hospitals are often far away from some of the population, and so about 1 in 10 patients are not able to make it to hospital to receive care. Of the patients who make it to hospital, only about 1/3 are able to recover to independence, are able to go home without a lot of help. And of survivors, almost 2/3 have cognitive impairment. When we test them, they have neurocognitive problems related to their subarachnoid hemorrhage. Now, early in their course in hospital, most of the focus is on fixing the aneurysm or securing the aneurysm, because the major threat to life and the major cause of morbidity is the re-rupture of the aneurysm, or rebleeding. But this is a disease which is like a marathon, a very long course. And over the next week in hospital, many patients will develop delayed cerebral ischemia, or vasospasm. And this actually accounts for 1/4 of all the morbidity and mortality related to their subarachnoid hemorrhage. So this represents both a very serious cause of disability, but also a therapeutic target. If we can address this, we can make huge gains in the outcomes of our patients with ruptured aneurysms. Now, this delayed cerebral ischemia is an acute neurological deterioration that occurs after their subarachnoid hemorrhage, typically between the 4th day and the 10th day after their rupture. Historically, we've attributed this to angiographic vasospasm. So vasospasm that we can see on angiogram. So here in this angiogram, you see the typical very tight vasospasm or constriction of the proximal intracranial arteries. The problem is that many patients have angiographic vasospasm without any symptoms. That we can often explain by saying, oh, they have good collaterals, or it's not, the spasm does not limit cerebral blood flow. But more problematic is the fact that many patients who have symptoms within that time frame, on day 7, day 8, and day 9, after their subarachnoid hemorrhage, have no demonstrable vasospasm on angiogram. And as well, about 20% of patients may actually have infarction demonstrated on CT scans without any clear vasospasm on angiogram. So clearly vasospasm is not the only driver of this disease. And hence the movement away from calling it vasospasm to its more recent or modern name of delayed cerebral ischemia. So I've suggested that this delayed cerebral ischemia is a multifactorial process. And this helps explain the differential impact it has on different patients. That some patients are symptomatic, some patients are not. We think now that there are probably 4 major causes or processes which contribute to delayed cerebral ischemia. The first is vascular dysfunction, which actually causes the vasospasm that we observe. There is likely also microvascular thrombosis, where there is a microvascular or endothelial dysfunction and small capillary-sized blood vessels actually become thrombosed or occluded. There is also a strong inflammatory component, not just of the blood vessels, but also of the brain itself. And there's glial activation. The glial cells become activated as part of their brain inflammation. In fact, in vessels that have spasm, we actually see tri-layer inflammation. Both the media, the adventitia, and the intima are all inflamed as part of that process. So inflammation is a major driver here. And the last, most recent contributor is this idea of cortical spreading depolarization. And we'll talk a little bit of what this is in a second, but this is also, I think, a major functional component which leads to worsening ischemia. So first, we'll go through each of those in sequence. So first, in terms of the vasospasm that occurs, the vasospasm that occurs, most of it is muscular spasm. We think it's actually precipitated or started by vascular inflammation due to the release of blood in the subarachnoid space. So the blood that's released scavenges nitric oxide, which is a dilator of the cerebral blood vessels. And the hemoglobin that is released then is reduced from oxyhemoglobin to deoxy and then methemoglobin. And those both scavenge vasodilators causing the spasm, but also set off a cascade of new inflammation in the blood vessel. Again, what's challenging is that not all vascular spasm is symptomatic, and not all patients with symptoms have vascular spasm. Patients who have very severe proximal spasm, like in this angiogram shown in this slide, obviously have flow limitation. But often you have patients with very mild spasm that should not be flow limiting, yet the patient has significant symptoms, or patients who have no spasm at all. And so those patients likely have either microvascular disease or other reasons for their delayed ischemia. Now, the inflammation that occurs after a subarachnoid hemorrhage is very complicated. And I'm not a specialist in inflammation or a lab researcher. But here's a great reference, if you're interested, about how this spilling of blood into the subarachnoid space sets off a cascade of inflammation, both in the perivascular space, but also in the blood vessel itself. And remember, there is a very strong connection between inflammation and thrombosis, right? In invertebrates, in fact, those two processes are the same thing. The immune system and the hemostatic system are the same. And in humans, inflammatory or anti-inflammatory treatments have been and as well anti-thrombotic treatments have both been treatments for sepsis because of this linkage. So it's important to note that the inflammation that's caused by the subarachnoid hemorrhage actually also induces microvascular thrombosis, or is a prothrombotic state. And we think this also is potentially a target for therapy and also leads to some of the infarction or the silent infarction that we see after a subarachnoid hemorrhage. And the last, most recently described contributor is the phenomenon of cortical spreading depolarization. This is also, or was initially described as cortical spreading depression. This is a functional or a physiologic observation where there is a loss of organized cortical electrical function. And it's because of the loss of ion channel homeostasis. The neurons are unable to maintain their usual ion gradients. We observe these in many brain injuries, in traumatic brain injury, after, in status epilepticus, or at onset of status epilepticus, and also after subarachnoid hemorrhage. So there is also not only a excitable state of the brain where the metabolic workload is high, and the organized function of the cortex breaks down, but they're also associated with abnormal vascular responses. So what happens is, instead of the usual increase in cerebral blood flow that we would see because the brain is depolarizing, or that area of cortex is depolarizing, we see instead a reduction of cerebral blood flow. So there is a reduction of regional blood flow associated with the spreading depolarization across the brain. And so we think that as this depolarization spreads across the brain, there is actually a decrease in cerebral blood flow that exacerbates or worsens the cerebral ischemia. This worsens ischemic injury. And in fact, in some early studies, the detection of these spreading depolarizations that spread across the cortex at between 3 and 10 millimeters a minute, they just spread across the surface of the cortex, actually predict subsequent infarction that are found after subarachnoid hemorrhage. So potentially both a source of surveillance, or to be able to detect patients at risk of infarction, and maybe with time we'll be able to use this as a therapeutic target to reduce these widespread depolarizations. Okay, so we've talked a little bit about how the pathophysiology of delayed cerebral ischemia is not completely understood and is quite complicated. So how do we detect it? Well, the clinical exam is key, and it's easy. In a good grade subarachnoid hemorrhage, where they have a useful clinical exam, it's very easy. We can detect very subtle asymmetries or changes in their neurological exam. The challenge is that in patients who have a decreased level of consciousness, or who are in the intensive care unit with a mechanical ventilator, their clinical exam is often very limited. And so we have a huge problem, because the steps between, let's say, their levels in the GCS, or once we detect a change, in fact, the amount of neurological injury that has occurred is much greater. So we need to find some other way of detecting delayed cerebral ischemia. Typically, we've concentrated on blood flow, so the vascular component. So we look at transcranial Doppler. More recently, we've also been trying to look at actual brain perfusion, not just the flow in the vessels, but what the brain is actually receiving, and whether it's a mismatch. So we can use CT perfusion for that. I think there's a lot of interest in using a more functional tool or exam. For example, either cerebral autoregulation, EEG or electroencephalography, or even pupilometry. So we'll talk a little bit about those. I will spoil any enthusiasm. None of these surveillance tests are great. They all have limitations, which makes the detection of cerebral ischemia in patients who already have decreased level of consciousness very challenging. So transcranial Doppler historically has been very commonly used for detection of delayed cerebral ischemia. It is straightforward because it's very widespread. It doesn't require necessarily a lot of technology, although you still need a machine. And you measure flow velocities. And as the vessel becomes spastic or develops vasospasm, because of the decreased size of the blood vessel, the velocity goes up. And patients with high velocities likely have spasm. Now, there are many more indices or things we can look at with transcranial Doppler to help us determine whether this is delayed cerebral ischemia. I'm giving you a very simple presentation. But the challenge is that, as I discussed already, not all patients with delayed cerebral ischemia have large vessel spasm. And thus, the accuracy of transcranial Doppler to detect DCI is much lower. So here's an example, a patient who has very high velocities. And you can see on that, this is the MR angiogram that was performed in the patient, obviously much more, very tiny spastic vessel, the velocities are very high. On the contralateral side, where the vessel is more normal size, you can see normal vessels. So that is typically what we see. Here is an example of a patient we had in our unit where we actually had pulse, like two-dimensional Doppler or pulse wave Doppler, where you could actually see the MCA traveling out towards you, and it's the ACA traveling away from the carotid bifurcation, sort of medially and anteriorly. And there's the back, the other side of the contralateral skull we see on the image. So there's an idea of the anatomy. So you get a sense already of the fact of how there is a significant technical component to this, regardless of what technique you're using. That's very operator dependent, and that's a major limitation of transcranial Doppler. And so, for example, you often need to find bifurcations or find landmarks to identify vessels, and it's very difficult for two individuals to necessarily have very accurate, very close readings, very accurate readings. Two individuals often have slightly different technique or slightly different position and may get quite different numbers. Sometimes one will find spasm and one will not, and this is obviously a major problem with accuracy. And again, this only detects the flow velocity or pulsatility changes in flow related to vessel narrowing. And what about the 30% of symptomatic patients who do not have large vessel spasm on angiogram? And so TCD does not really help us with that subset of patients. So one other approach is to look at CT perfusion. And so this has been especially helpful, I think, in our patients who are in coma, or when it isn't clear whether this is vasospasm or some other confounding problem in the ICU, fever, sepsis, a metabolic problem that's leading to a decreased level of consciousness or neurological change. And so you can see here the sensitivity and specificity of using CTP and just looking at the pictures, having the radiologist, the expert, look at the pictures and see if there is a mismatch or an area of hypoperfusion is not fantastic. It's better than nothing, but still only is 84% sensitive, and its specificity is still not even 80%. So this is not a fantastic tool. If you see something, it's very reassuring, but I think it really lacks significant sensitivity to find all patients with delayed cerebral ischemia. And so here's an example. You can see this is the day 4 CT, and here's the CT perfusion on that same day in a patient who was suspected to have delayed cerebral ischemia. And you can see here there's a mismatch, an area where there's an increased mean transit time on the CT perfusion, demonstrating early delayed cerebral ischemia or an area of hypoperfusion of the brain. Trying to have the computer or the machine actually look at various areas of the brain and calculate areas of mismatch, which has become very popular in software, looking at helping to guide endovascular therapy. So if you use Rapid or some other proprietary software to do these calculations for you, unfortunately, that strategy has not been helpful. The positive predictive value of finding of CT perfusion, of this quantitative analysis, is still not great. And so it is still not better than having the radiologist read the scan itself. So unfortunately, it does not appear to be very helpful. And finally, this is some of my colleagues did this study looking to try to see, well, if we already suspect a patient has delayed cerebral ischemia, does CT perfusion help? And the reality is no, because our clinical suspicion is already better than what the CT perfusion does. So if you have a clinical exam, there is no point, obviously, doing a CT perfusion. But it still, I think, has use in patients who don't have a reliable clinical exam. Or, for example, a patient who is sedated on a mechanical ventilator because they've had a subarachnoid hemorrhage and also had an aspiration and now have a pneumonia and is on a ventilator. Their exams are much less sensitive for changes than a patient who is awake. And so CT perfusion can sometimes be helpful in this population. So is it possible to do better than CT perfusion or a study of brain vessels and actually look at brain function? Can we do pupilometry, EEG, or autoregulation? So the challenge is that all of these functional assessments have increasing complexity or skill required. So I'm not sure if many of you have exposure or use of pupilometry, but this is a device that will actually provide a quantitative measure of pupillary reaction, not just the absolute constriction, but actually the velocity of constriction, and provides an index of the absolute, I guess, responsiveness of the pupil. And there was some interest that maybe changes in pupillary function might be an early sign of evolving ischemia. So unfortunately, that was not borne out by the studies, and this has not been helpful, which is helpful in our ICU because these devices are quite expensive. And so it was another reason for me as the director not to order more expensive technology that didn't work. So that was, unfortunately, it did not work. The upside was this was a very expensive way of doing this. Another option might be to look at cerebral autoregulation. So there are ways where a computer can look at the pulsatility of the ICP or of the arterial waveform and look at correlation between what's happening in the heart and how it impacts flow in the brain. You can do this also through transcranial Doppler. And if you, this MX, or the correlation coefficient, is 0, it means that no matter what is, the input pressure is to the brain, no matter what the heart is doing, the brain is able to auto-regulate so that it gets what it wants. As you get close to an MX of 1, it means whatever the blood pressure does, the brain blood flow does. So if the blood pressure is low, the brain cerebral perfusion is low. If the blood pressure is high, it's high. And so obviously we want a low value. And so one way is to look to see if changes in autoregulation predict evolving delayed cerebral ischemia. And also, unfortunately, that was not shown to be very sensitive. If you saw it, clearly the patients had delayed cerebral ischemia. So it had very high specificity, but the sensitivity, unfortunately, was quite low. And so here are just some more studies for your interest or for reference. Even in conjunction with TCD and near-infrared spectroscopy or other kind of non-invasive monitors, none of those were really demonstrated to be very helpful in detecting changes in autoregulation that predicted vasospasm or delayed cerebral ischemia. So unfortunately, this did not come through as a useful tool. I think most interesting is the idea that maybe we can actually look at a true cortical function. So let's look at continual EEG or to predict vasospasm. And there's a lot of interest in evolving changes in the alpha-delta ratio, the ratio between alpha and delta activity, or the proportion of each, to predict the development of vasospasm. So this is from the ICU group in Colombia, under the leadership of Jan Klaassen, who did many of these studies. And they actually show quite good evolving specificity and sensitivity with this. And they're actually developing a monitor that will actually monitor this in real time. One of the challenges is, at least in Canada, many of our neuro ICUs are not actually staffed by neurologists or neurointensivists who have formal training in EEG. They have maybe only preliminary training as part of their, as part of their general training. And so it is very hard to operationalize this because we don't have a lot of continual EEG in Canada. And so this is a real challenge. And many jurisdictions have limited EEG capability. And so the idea that you're going to be monitoring, 3 or 4 patients with acute subarachnoid hemorrhages for, 10 days is obviously not practical. There have been a lot of suggestions that maybe we can get away with a fewer number of electrodes, a very simple monitor that will give you some sort of map of their alpha delta ratio that can be used or interpreted by nurses or physicians at the bedside. And these are coming, but they are still not, I think, commercially available, but certainly would solve a lot of the problems that are involved with a very technical and resource-intensive monitoring system, being EEG. All right, so by this time, I hope that you've all been convinced that delayed cerebral ischemia is an important problem in this subgroup of patients. We have a hard time detecting it, but when we do detect it, we want to treat it aggressively because we hope that there is an opportunity to improve the outcome of our patients. Obviously, the goal is to improve cerebral perfusion and prevent infarction and improve decrease disability and improve outcomes. Historically, this was triple H therapy: hypertension, hemodilution, and hypervolemia. We now know this does not work, so we need a different approach, right? Triple H, the 3 treatments combined, are just simply do not work. In fact, I'm going to show you some data showing how some components, hypervolemia and hemodilution, actually undo any benefit, if there is any, of hypertension. So in fact, the elements fight each other. We now, in our center, take an approach of very careful hemodynamic augmentation. We want to very gently induce hypertension. We want to be very careful with our fluids, aiming for euvolemia. And I'm going to talk a little bit about Milrinona as a therapeutic option. So first, let's talk a little bit about hypertension. This is a seminal paper in neurocritical care by Elke Munch, who did a very elegant study looking at the individual effect of hypertension, hypervolemia, and then hemodilution in randomized order to really try to determine what the impact of each element of triple H therapy was. So she had a fantastic study. What I've circled here is actually the first H is hypertension. So what I want you to see is the improvement in both cerebral blood flow and the impact of and the improvement in brain oxygenation with hypertension by itself. So although this is still somewhat controversial, there are some areas, so in Belgium and the Netherlands, where they do not believe that hypertension, at least very high doses, high blood pressures, are beneficial. We still believe that mild hypertension titrated to clinical effect, if they have a clinical exam, is beneficial and improves cerebral perfusion. This is especially true in patients with demonstrable angiographic spasm because of the requirement for a higher pressure to get past that area of vasospasm. Okay, so what we typically do in our center is to increase their mean arterial pressure by about 15, or increase their systolic blood pressure to about 180 or higher in patients whose aneurysm is secured, and follow their clinical exam or CT perfusion. So hypertension appears to improve both cerebral blood flow and brain tissue oxygenation. So of the elements of triple H, I'm going to tell you this is the one which actually had demonstrable effect. The other major component is was usually fluid loading or IV fluids. There is no doubt across many brain injuries that being hypovolemic or not having enough intravascular pressure is an incredibly bad thing. Patients do very badly. Yet, being hypervolemic or having too much fluid is not good either. It does not necessarily improve your cerebral perfusion. In fact, the administration of fluids is one of the most complicated things that we do in the ICU because nothing is straightforward. It all depends on what fluid you're giving, whether you're giving crystalloid or colloid or anything else, what their state of their vasculature is, how much of it leaks out, and ultimately what their cardiac status is. If I'm giving more fluid, does the brain get better because primarily because the volume of their blood expands, or does it get better because I'm improving their cardiac output? And then there is also no guarantee that improving cerebral blood flow actually improves the perfusion of the brain or the transport of oxygen from the blood vessel into the neuron itself. So there are many factors which will impact whether the liter of IV fluid that I administer actually improves the brain function. And in fact, in multiple studies, and I'll show you just a few, we see that increasing IV fluids, in fact, does not improve cerebral blood flow or outcomes. So this is one study, a randomized study, where they actually gave a lot of fluids and found as they gave fluids every day, the fluid balance obviously was very high. Their CVP and their pulmonary artery diastolic pressures, their wedge pressure was high, meaning their heart was very well filled, maybe even overloaded, but their blood volume and their actual fluid balance, like on, not their fluids on each day, but at the end of day 3, they'd peed out all of that extra fluid. And so at the end of the day, in fact, their balance, as you can see here, was very similar, okay? And so what I'm trying to show you is that just giving the fluid, in fact, doesn't necessarily improve their cerebral blood flow. Because this is, when I trained, this is what we did. Every patient with a subarachnoid hemorrhage, once they developed delayed cerebral ischemia, received liters of fluid every day in an attempt to promote hypervolemia. But in fact, they never really obtained hypervolemia. Their blood volume never increased. And in fact, this one study by RAS, published last year, demonstrated that high fluid intake was actually associated with poor outcome. So in fact, even if the fluid balance did not change because the patient then passed urine and got rid of all that extra water, just giving them all that fluid day after day was actually associated with poor outcomes. And so even when they accounted for multiple other complications, for example, anemia, heart failure, and pulmonary edema, pneumonias, all of those things, that the amount of fluid that they received, if they received a very positive daily fluid balance or daily fluid intake, we were giving them lots of fluid, they had much worse outcomes at 3 months. So clearly this is a case of more is not better, right? We need to make sure they are not hypovolemic and they are not in shock, but we don't actually want to promote hypervolemia because it doesn't work and it seems to worsen outcomes. Okay. And then back to L.K. Munch's study, and this was, I think, what really convinced many neurointensivists that this didn't work, that if you had an improvement in cerebral blood flow and in brain oxygenation with hypertension, if you then loaded the patient with a lot of fluid to try to make them hypervolemic, that's this one, it actually undid the benefit of the benefit of the hypertension. In fact, here you actually had a worsening of brain tissue oxygenation related to increasing fluid. I didn't show these slides, but there's a very elegant study done at Cambridge by David Menon's group, showing that one of the biggest determinants of brain tissue oxygenation is actually the diffusion of oxygen from the blood vessel to the neuron. And by increasing cerebral edema, by hypervolemia, you actually create a block, an obstacle to diffusion of oxygen. You make it harder for the oxygen or a longer journey for the oxygen to get to the neuron through this edema. And so this, I think, helps explain the physiology, why hypervolemia reverses any benefit you get from pushing more blood at a higher pressure into the brain. The more blood gets past this vasospasm or past the thrombotic capillary, but then it has a harder time with the high blood pressure, with hypertension, but then it has a harder time crossing over from the vessel into the neuron because of the hypervolemia, because of all the fluid that we've given. So for all of these reasons, we have now moved to maintaining euvolemia in all of our patients. We don't want to promote hypervolemia or hemodilution. Okay. And finally, it's important to note that the idea of hemodilution all came from mathematical models that suggested that the best rheology, the best blood flow would occur with a hematocrit of about 30. But these were not physiologic models. These were all very simple. And so it's in clinical studies, when we evaluate this, it's become clear that as we induce hemodilution, as we make people's blood thinner, even if you do it in an isovolumetric way, we keep their blood volume the same, but then we make their hematocrit lower, it increases cerebral blood flow as compensation, but you actually decrease the overall delivery of oxygen to the brain. And when we do PET scanning, we actually see that more brain is actually at an ischemic threshold. We increase the volume of ischemic brain. So hemodilution, just like hypervolemia, in fact, was doing the opposite of what we wanted. So I hope I've convinced you that the idea of Triple H, as it was described, 2 generations ago, 20 years ago, of physicians, doesn't work. And we need a different way of approaching that. Okay, so I already spoke a little bit about how we still use hypertension as a first-line therapy. We ensure that they are volume replete, and we increase their blood pressure to try to address spasm, especially in patients with demonstrable spasm. In a patient who has no proximal vessel spasm, to be honest, I tend not to be very aggressive about hypertension. I just do it very mildly. There has been a lot of interest about using Milrinona as both as a cerebral vasodilator and also an inotrope to increase cardiac output. This is a phosphodiesterase inhibitor. I'm not sure if many of you have experienced using it. In intensive care and cardiac care, we've used it for a long time for patients in heart failure. Its first use in vasospasm was about 20 years ago in a very elegant study, which used it both intra-arterial as well as systemic administration. And so this was that original study showing angiographic reversal of a patient with severe cerebral vasospasm with intravenous arterial and an intravenous Milrinona therapy. So here on the left side of the screen, you can see the patient has in that just into the M1 branch of the MCA, you can see just really very severe spasm and some focal spasm of the ACA. And then subsequently, after the intraarterial and systemic Milrinona, you can see really a lot of that spasm has resolved. The flow through the distal branches of the MCA and the ACA have improved. And so this was a very effective therapy in the angiography suite when given intraarterially. And so the question was, could we use it systemically giving it IV to improve cerebral blood flow. So this really became popular at the Montreal Neurological Institute, where they had began to move away from hypertension, volume expansion, for all the reasons that I've outlined already, and started using Milrinona to improve cerebral blood flow by cerebral vasodilation. They also did, a lot of, the protocol involved a lot of homeostasis, normalizing their sodium balance and all sorts of other things. But really the key difference of this protocol compared to others was the use of Milrinona. Here it is in graphical format, but obviously once you actually make the diagnosis of vasospasm or delayed cerebral ischemia, then you start the protocol. Now, what is interesting, and you may not notice, is that usually in cardiology for heart failure, we start at 0.25 to 0.75, so the doses are much lower. For the brain, we use much higher doses. We start at 0.75, which is the upper limit for the heart, and then we go up to, up to 1.25 or sometimes even 1.5 mics per kilo per minute. So we use very high doses of Milrinona. Okay, so the idea is we do this. Only if their mean arterial pressure is low do we actually use inotropes. We actually just leave them on the Milrinona. And then if there's no improvement over time, we consider either escalating doses or we'll take the patient to angioplasty if they have lesions that are amenable. So this is typically how we go about doing it, with very high doses of Milrinona. You have to give a bolus. The half-life of Milrinona is very long. So if you just start the infusion, it will be hours until you reach steady state or constant levels of Milrinona. You have to give a bolus to start. Unfortunately, there are no randomized controlled trials that really give us very good data of whether this works. Margolanis and Jean Teitelbaum at the Neuro published this series where they looked at 500 patients over time and compared them to historical cases they had. Obviously, this is a problem because the care of these patients changed dramatically over 10 or 15 years. And so it's hard to compare patients. But what they did find is that about 2/3 of the patients still needed blood pressure support with the Milrinona. But they continued it for 10 days. So they continued this therapy for quite a long time. Okay, but they didn't have any episodes of heart failure or cardiac ischemia. This I find is actually quite amazing, because when we augment our patients in the old, if we're inducing hypertension and we're raising blood pressure to, let's say, 180 or 200 millimeters of mercury, for many of our patients, continuing that for 9 days, we would surely have patients with heart failure or pulmonary edema or cardiac ischemia. That is a very high blood pressure to have for a week. But these patients were relatively asymptomatic, which is quite amazing. Okay. It is not entirely clear what the best dose is. Clearly, when we give 5 or even 8 milligrams as an intra-arterial bolus, that is a huge dose of Milrinona, that we expose the blood vessels of the brain to. And so they dilate very rapidly. It's not clear what dose we need to give intravenously. And so this is one study that tried to identify this with fairly large boluses, and again, doses that were quite high. Again, found that it was very well tolerated. It did not look necessarily at what the effective dose was in terms of neurological outcomes, but this was helpful at documenting the safety of Milrinona and this approach in dealing with delayed cerebral ischemia. One thing we do in our patients who we don't have a reliable clinical exam on is we actually use CT perfusion or repeated CT perfusion to document therapy. Because we obviously, if we don't have a clinical exam, we don't know how high the Milrinona should go or how high their blood pressure would go. So this was one paper that was published by one of our fellows, our neurocritical care fellow, and some of my colleagues, looking at how we can demonstrate. This is at before the start of therapy. This was their CT perfusion, and you can see bilaterally in their ACA territory, they had areas of mismatch, of delayed cerebral perfusion or delayed transit time, and an area of mismatch on their quantitative analysis. And then with the institution of Milrinona and their blood pressure being raised by 15 points, a dramatic resolution of their mismatch and an improvement of their cerebral perfusion. And then here is our follow-up scan further on. So you can see that we actually use the changes in CT perfusion to guide therapy. We talked earlier about how CT perfusion was not useful necessarily as a screening tool with a clinical exam, but in patients who their exam was confounded or you can't examine them clinically, then it's quite useful. And then finally, in patients who we're unable to improve their symptoms, we will then actually move to angioplasty, which is for patients with proximal spasm. And this obviously is very effective at improving the proximal spasm, but often does not completely resolve their symptoms, although the hope is that it prevents widespread infarction. So this is our final therapeutic option when everything else fails. Okay, so I'll just conclude and we can answer some questions. Obviously, we've talked about how delayed cerebral ischemia is very important and a real challenge. If we detect a DCI in clinical exam, that's very helpful. But in many of our patients, it's quite challenging because their exam is not reliable or confounded. Our historical management of HHH is largely discredited. It does not work. We still use hypertension, not all centers do, but we still use hypertension. Our goal is euvolemia, so we avoid hypervolemia. And then we consider Milrinona quite early in patients whose exam or CTP does not improve very quickly with those conservative measures. And that Milrinona is typically a much higher dose than we would typically use for cardiac causes. And so finally, I'm always happy to field questions, but there's my my contacts. Every year we run a neurocritical care masterclass as part of our national meeting. So if you ever have the opportunity to travel in the fall to Toronto, to Canada, please feel free to come and touch base or come to our class. It's fantastic. And there is our Twitter handle, so please feel free at any time to reach out and touch base. All right. I look forward, hopefully, to meeting some of you in person and at some point in the future. So with that, I'm going to stop sharing my screen. I'm sorry, now it's gotten dark in my office, so now it's quite dark. But I will open up for questions. So thank you very much for your attention. It was really an honor to get a chance to speak with you. I'm sorry we couldn't do it in person.
Thank you, Dr. Singh, for that great presentation. So we've got time for some Q&A. I've received several questions so far, so I'll try to put together some of them. Okay, so there are some trials that suggest that we can use some early perfusion studies with CT angio in the first 24 to 72 hours after subarachnoid hemorrhage, and maybe those studies could predict vasospasm before it's even clinically relevant. So what do you think about that?
I'm sorry, the question was if there were several studies that demonstrate, what was the modality that predicted vasospasm?
CT angio.
CT angio. Yeah, so the challenge, we do a lot of CT angiography. I will tell our experience is that although I'm familiar with those studies, that some of them demonstrate that the changes in vessel caliber predate the development of symptoms. One of the challenges we face is that it still doesn't catch the 30% of patients who have no angiographic evidence of changes. It also means that a number of patients develop angiographic spasm, but never go on to develop symptoms. And so the question is, if you identify patients who have evolving angiographic spasm doing serial CT angiograms, how then do you follow them? Or more importantly, in the patients who you can't examine, what do you do then? Do you treat patients asymptomatically just based on that? So we have not found that CT angiography is particularly helpful in this regard, why we've moved to CT perfusion. The challenge, of course, is that it's a lot of contrast. If you do many of these studies, the contrast exposure for the patient is very high, and so you have to keep that in mind. We're not less worried about the radiation as we are about the amount of contrast we're using with all of these different studies.
What do you think about CT perfusion in the first 72 hours?
So that's a very sophisticated question, or complicated question, because we know right after the subarachnoid hemorrhage, in the first 24 to 48 hours, there is a dramatic decrease in cerebral blood flow. That is not just related to ICP, but actually metabolic flow coupling and the immediate state of the brain. And so CT perfusions are often not very helpful in that first period, which presents a problem in patients who arrive, who might have had a sentinel bleed or a bleed preceding, who present with a new rupture or maybe a rebleed, and who also have a demonstrable vasospasm. That is a real challenge. So we typically do not do CT perfusions in that window for all of those reasons. It is typically later in the phase, so starting day 4, day 5 onwards. But it's a very sophisticated question, and those small number of patients who present late with a rebleed and present with vasospasm, there is a risk that the CT perfusion may not be helpful.
Okay, we have a question about the mechanism of Milrinone. So does Milrinone works by means of improving cardiac output, or does it work by direct vasodilation? So are there any trials with other drugs like those used for treating pulmonary arterial hypertension?
Yeah, those are great questions. So the effect on the brain for Milrinone is independent of the cardiac effects. And so that is really related to a direct effect on the cerebral vasculature through phosphodiesterase inhibition and the smooth muscle. There are multiple studies looking at other cerebral vasodilators. Obviously, as part of, we used to use piperavine, we used to use verapamil. None of those have been effective in a systemic level. It's really only been Milrinone. There have been a lot of interest in endothelin receptor antagonists, so the clazosentan studies. So we actually ran, those were called the conscious studies. So clazosentan is a endothelin receptor antagonist, which really had no impact, unfortunately, on a subsequent infarct. So that was not helpful, much to everyone's disappointment, because everyone was hoping that would actually work. So none of those usual drugs or the sildenafil or any of those drugs have actually been demonstrated to be effective, or other calcium channel blockers. So that's why I think there's a lot of interest in Milrinone, because of its mechanism of action, the direct effect on the cerebral vasculature, and the fact that it's, that really nothing else has worked. No other class of drugs has worked.
Okay, there is a very good question about spinal drainage. So there are a few trials of using a preventive spinal drainage to avoid vasospasm. So what's your opinion about that? What do you think about the early use of a spinal drainage?
So, like the spinal drainage used after the aneurysm secured and there's no,
right.
We do not do that in our center. There's been a lot of interest in it, in a way of removing, I guess, those blood products and trying to decrease the inflammatory load in the proximal blood vessels. So the use of volume-based lumbar or spinal drainage in some centers has become quite popular. I'm not aware of any definitive kind of trial data demonstrating an impact on functional outcomes. But to be fair, we don't have that data for Milrinona either. So I guess this is one of the interesting cultural changes. We do not use it on our site. And part of it is that, you know, my belief is that early studies that looked at this, when we looked at cisternal irrigation or patients that underwent clipping or coiling early to secure their aneurysm, there was really no impact of any other cisternal irrigation or clearing the clot or the hematoma in the operative setting on subsequent development of delayed cerebral ischemia. So I make the conclusion that then whatever inflammatory cascade is set off by that initial ictus, by that blood being spilled, draining it on the second or third or fourth day is not helpful. Like the cascade has already started. Now that's my feeling based on extrapolating those early data. And so that's why we typically don't do it. But that does not mean it's right. Again, we don't have functional outcome data. So I think it's very important that this question be answered because we need to know. My suspicion is it probably won't work because I don't think we get the blood out early enough. But that's my feeling.
There are a few questions about some other drugs. So what do you think about the use of statins and nicardipine, intraventricular nicardipine?
Yeah, so that's those are great questions. So statins, I think after the STASH study was released, we now feel do not have an effect, at least in terms of preventing delayed cerebral ischemia or their subsequent infarction. So we don't. So we typically don't do that at our center. The question then is, well, what about sort of the other drugs? So intraventricular nicardipine, or there's now intraventricular nimodipine. That's one of my other colleagues, Locke McDonald, who's at a different hospital in Toronto, was developing slow release or sustained release intraventricular nimodipine. I don't actually think that like for intraventricular nimodipine, that drug is still in early trials. The early trials look very promising in terms of addressing the vasodilation. Again, like Milrinona, it's probably going to be effective at treating patients who will develop vasospasm or delayed cerebral ischemia. You will give it to all patients, but I think both of those drugs, because they're predominantly vasodilators, are only going to improve the the blood flow in patients who have delayed cerebral ischemia. I don't think it's going to change the course of the disease because most of the disease is not because of this muscular spasm, it's because of the inflammation. But I think they're very interesting therapeutic targets. The challenge is this: who would I give all the intraventricular nimodipine to? Would I give it to all patients, or would I only give it to patients who then, let's say, look like they're at high risk? Because of course, every time we access their drain, we increase the risk of infection. Right. And so it's a really great question. I'm just not sure where the best use of that drug is going to be. But I think as an idea, the idea that we give a depot that's slowly released over time is very, very provocative. Or I like that idea. I think it's a great one.
We're receiving a lot of questions, so I really apologize if I'm skipping some of them.
That's okay. I'm sorry it's so dark here. It got dark very quickly, and even though I have turned my lights on my camera, it's not working. So I'm not really in the dark. I'm so sorry.
It's okay. So I'm getting the same question sometimes, for a few times. So what do you think regarding the neuroinflammation and the microthrombi phenomena in order to use antiplatelet therapy such as cilostazol?
Yeah, I think there was certainly an element of early platelet adhesion. So antiplatelet agents may have some benefit there, but I think really at least I'm extrapolating from my critical care background, where in sepsis there was a lot of interest in activated protein C and other thrombin modulators, because thrombin itself is highly inflammatory. And so, you know, I think if there is, and Gabriel Rinkel is doing these studies as well, looking at heparin and other sort of antithrombotic therapies, so not antiplatelet therapies, but other antithrombotics, about whether decreasing the balance or changing the balance between coagulation and thrombosis, whether we decrease the amount of thrombin that's being generated, we can decrease the overall inflammation. That's the hope. But again, those studies are ongoing. But I think it'll probably won't be aspirin or ticagrelor or any of the antiplatelet agents. It will likely be an antithrombotic agent because of that link between thrombosis and neuroinflammation.
Okay. What do you think about the optimal mean arterial pressure in patients after securing the aneurysm? Obviously before developing clinically relevant vasospasm, or even if they don't, because some patients don't develop vasospasm. So what do you think about the optimal MAP in patients after securing the aneurysm, regardless of the future outcome?
There we go, that's better. We typically keep our systolic pressures after they're secured at whatever the patient will auto-regulate. So we're quite aggressive at bringing the blood pressures down in that first 24 hours while we're racing to secure the aneurysm. But once we've done them, we let the patient auto-regulate. We normally don't try to maintain either a high or low mean arterial pressure with the expectation that the patients will have reasonable auto-regulation. I realize that obviously that logic might be flawed because patients after a severe subarachnoid hemorrhage might have impaired autoregulation. But then the thought is, if we lower the blood pressure or we raise it and they have completely impaired autoregulation and are passively dependent on their blood pressure, if we change their blood pressure, we might actually make things worse. So in the absence of either some other data demonstrating that they are at high risk, let's say they had a very large intraparenchymal bleed or already have a large infarct, we typically, once they're secured, let their blood pressure be whatever the patient wants it to be and try not to adjust it, obviously unless it's at a dangerous level. We just let them auto-regulate, understanding that, in fact, their autoregulation might be impaired, but then they're even more sensitive to me making the wrong decision. So we opt to not make any decision.
And what would be those dangerous levels?
I think typically if their systolic was consistently higher than 180, or obviously lower than, sort of 100, 110, then I would intervene. With the exception of patients who have significant infarcts or like a large intraparenchymal hematoma, those patients we might treat a little bit differently, mainly because they already have underlying injury. So we might control them a little bit tighter in that situation.
Okay. Dr. Brunetti is asking, what do you think about the recently published evidence, stroke 2020, about using goal-directed therapy with transpulmonary thermodilution, PiCO2, to guide the hyperdynamic therapy during management of DCI? Right.
Wow, that's a great question. Sorry, my talk wasn't as sophisticated as that. So we don't do either LIDCO or lithium or transpulmonary thermodilution here, mainly because it's kind of a technology and the cost isn't readily available to us here. But the idea would be that would allow you, transpulmonary thermodilution is a technology which would, non-invasive technology that allows you to calculate the cardiac output, manage their extravascular lung water, and also, gives you a number of other indices. And so you could feel much better about titrating your therapy to minimize the effect on the lung and the volume overload and improve the cardiac output. My only, conceptual problem with that approach is it's focused on the heart. And what we're really caring, we're really focused on the brain. So I always tell my trainees, this is the brain pump. Okay, I got, all I want it to work. And so, although that gives you a lot of information, it doesn't really give you the information about the organ that I'm most concerned about. And so ideally, so we don't use it here. I think it's a fascinating way to prevent the adverse effects of your therapy. But generally, we shouldn't be having a lot of extrapulmonary lung water because I'm not aiming for hypervolemia. Certainly, it would help guide whether I needed a bolus to improve cardiac output. But typically, especially if I'm going to start Milrinone, I know their cardiac output is going to be very high because I'm using much higher doses than my cardiologist friends would use for heart failure patients or transplant patients. And so really what I would, ideally if I could dream, I would have some sort of neuromonitor that would provide a global or regional brain tissue oxygenation, but not just in one tiny spot like a Lycox, but all over the brain that would help me actually provide a sensitive map or marker of the brain. So we typically don't use those technologies here, but I understand they give you a lot of information. So if you are polyloading or in a patient with LV dysfunction, that would be a great therapy.
Dr. Herrero is asking regarding the spreading cortical depolarization. What do you think about the use of anti-seizure medications such as topiramate?
All right, well, I will acknowledge that I have absolutely no experience in treating or what to do with cortical spreading depolarization. I think I worry about, because I started as being an intensivist and then became a neurointensivist. So I was a late convert to the brain. In intensive care, so much of what we do has unexpected consequences. And for example, in many other diseases, there's a very clear there's a observed dose-response relationship between exposure to phenytoin and poor neurological outcome. Now, many people say, well, phenytoin or phosphenytoin is a terrible drug. We have better drugs now. But that being said, I worry about without a very clear pathophysiologic rationale for using a drug like topiramate or levetiracetam or brevitiracetam, whatever, I'm not sure that arresting those cortical depressions might actually might improve outcome, or do we just see the adverse effects of the drug? It's also possible that the cortical spreading depolarizations, although pathological, in fact, are just an epiphenomenon of a larger cortical injury that we're only beginning to understand. So although the cortical spreading depolarizations are associated with vascular abnormalities and worsening ischemia and infarction, it may be that trying to prevent them through topiramate, deep sedation to shut down all cortical activity like barbiturate comas might produce much more damage than they are helpful. So acknowledging I don't have any experience in treating them in that way, and I think there's a lot of interest in how to prevent them. Just from a conceptual standpoint, I would really would want to have a better understanding of what those depolarizations mean and what's driving them before we pick a therapeutic target. Otherwise, we might treat something and see it, we'd stop all the CSDs and feel good about that, only to find that in fact we've created another set of problems. We see that in so many things where we realize the surrogate outcome that we look for, let's say hematoma expansion in intracerebral hemorrhage, is not actually valid because it's masked by, it's traded off by other adverse events.
Okay, so it's getting late and we're getting a lot of questions, but we're probably going to, when we're for the last one, what do you think? Well, there is an association between poor prognosis in critical care patients and hypomagnesemia. What do you think about a routine measurement of hypomagnesemia and subarachnoid hemorrhage? Well, if you think it's a good idea, and if it is a good idea, when to do it?
Yeah, great question. So I think generally I aim for normal magnesium levels. In fact, I aim for in subarach, I aim for a magnesium level of 1. I have no evidence to back that up. That is just what I do. I think we know after the MASH studies that like super physiologic magnesium supplementation does not improve neurological outcomes, unfortunately. And so, in fact, just leads to problems because people are floppy because I have such high magnesium levels. It's also really helpful because trying to get someone's magnesium level to a very high level is often very difficult in the critical care setting. So I do not try to do anything special with magnesium. Our usual normal range is 0.8 to 1 millimoles per liter, and that is what we replace them at. We routinely check magnesium with every blood work. That is because we have a panel like at our Meyer system that will check all the extended electrolytes at once. And so that's what we do. I guess I've never thought about if there is a specific time to do it. You know, it often is quite difficult to replace magnesium, especially if there are other electrolyte imbalances. Trying to fix magnesium when your potassium is low or vice versa can be quite challenging. And so I guess my advice would be, I would probably check it early because if it's low, it might actually take you some time to correct it. I'm still not convinced that correcting it makes a difference to neurological function. However, if you're going to check it, you should check it and fix it. You might as well do it early. I'm not convinced that magnesium has really had a huge impact on neurological function. But again, a lot of these electrolyte imbalances we didn't appreciate in the context of cortical spreading depolarizations. And so maybe there is a real opportunity to find new therapeutic targets there, or to titrate our electrolyte or ion homeostasis a bit better.
Very well. Dr. Singh, thank you very much for your time. I know it's a big effort considering your position and also because you're on ICU call this week, so we're actually drawing you away from work, right?
It was absolutely my pleasure to get coverage. I really enjoyed speaking with you. I hope one day we can do this in person instead of by Zoom, but thank you very much.
Thank you very much, Professor Singh. Bien, pues damos entonces las gracias a la audiencia. Muchas gracias al doctor Singh y a Mario Riera, que lo hizo muy bien. Les recuerdo entonces que tendremos otros seminarios más que vamos a estar avisando en su debido tiempo. Y bueno, ahí pueden leer los siguientes: neuropatía fibra única, prevención secundaria de infarto cerebral, distonía. Y también les recuerdo que la última semana de octubre es el Singh, que habitualmente se hace en julio, pero en este año por el COVID lo dejamos para la última semana de octubre. Esos son algunos de los speakers que tenemos confirmados. Se van a agregar más. Así que para no alargar más el webinar, muchas gracias de nuevo y nos vemos la otra semana. Muchas gracias.